Yep.
Here we go.
Here we go.
You're on.
Let's come up.
All good.
All good. You got slides, you got audio. Don't worry about my face.
Good to go, Dave.
Good to go. Righto. Thanks for the intro, Dave. Yes, as Dave said, just trying to, I guess, for a lot of us, like what you've heard today might be a little bit confronting or contrast with what we were all taught back at college. There's always something new that's going to pop up in this industry. It's really hard to take that back and plug it in with what we initially were taught. So just to give a bit of a contrast between, I guess, the more classic approach, so how most people would be trained at college and how I guess a lot of people still approach manual therapy. So from a consultation point, it's very much led by the therapist, a fact-finding mission with predetermined questions. I know myself, I was taught 20 golden questions to ask. And based off that, we just moved straight into the objective examination. So looking at posture, and we're looking for right and wrong. And then things like range of motion, it was all, is that enough range or is that inadequate? And that was just compared against just a baseline number. So that's a number that comes from a collective average. Then orthopedic testing or special testing, I guess, was put up very, very high on a pedestal in my training in particular. And that was to identify dysfunctions, pathologies, or problems. And then treatment plan and intervention was very much just looked at finding faults in the tissue or their position. And then you picked a modality that targeted that particular tissue or that problem. And then same with the explanation, it very much followed that same blend. Versus if you look at more of a, I guess, a modern approach to things. So a lot of the, I guess, the topics covered today makes my job easier to talk about this afternoon. So from a consultation point, it's very much just facilitated by the therapist, but we're aiming more to have a bit more of a discussion that's led by the client. So really trying to understand what's brought them in and what they're looking for our help with in the session. And that isn't just on initials, that can be on an ongoing basis. And then we're trying to actually understand the client's experiences, past and present, and what their actual goals are, where they want to be heading. So I guess as a therapist, we're always going to have that little bit of an agenda that we want to cover. I guess we've got a duty of care and responsibilities to make sure that we're not going to put our clients at risk. And sometimes they're not going to volunteer some of the extra information that we need. But it's really important that they have an opportunity to be heard in that consultation phase. From a, I guess, an examination point of view, things like posture, I guess the more I dug into literature and trying to understand like what is good and what is bad, all that we tend to see is that it's just adaptive, fluent, and it doesn't really indicate dysfunction. And it's more of just a reflection of behavior. So if someone has a sore shoulder, they're probably going to come in a protective position that makes their shoulder feel better. So when you're looking at that postural assessment, it's not really going to tell you why they're adapting that posture. But if you let them have their say in the consultation phase, you'll probably understand why that's a preferred postural behavior. So necessarily changing it may not be the quickest route to, I guess, a successful treatment outcome. So same with range of motion, a swimmer's range of motion versus your everyday therapist. They're going to be two very different, I guess, levels of expectation and levels of meaning. So a swimmer will need a huge range of motion, whilst a therapist probably not so much in the shoulders as an elite swimmer. Same with orthopedic testing. The more they dig into it, the less impressive it becomes. But it's also, when you break it down, we're just looking at how people move and how they engage the environment and what different bones and what joints are moving into those positions, how well they are moving. But as far as identifying exactly what tissue or exactly what the dysfunction is, not many tests do a great job on their own. Some are improved in clusters, but for the most part about what we need to do, it doesn't tell us how we need to approach every problem. But as therapists, we've again got that duty of care to go, hey, these things aren't adding up. They're not making sense. Do you need to refer and get an expert opinion on the matter for someone who can help fill in those gaps? And then I guess for us too, like treatment planning and intervention, how that's changing. traditionally, most people are looking at tissue-based interventions. Yet we're going to dig in today and look at the different mechanisms that we, I guess, affect change in the body and how people express their tissue qualities. But also looking at the things we do and we say and how that can have an impact on it as well. You see this all the time in the Facebook groups online or even just in the clinic with questions, is people going, how do I do this? How do I do that? What do you do to treat this pathology or this presentation? And the answer is usually a modality-based approach. So I like to use dry needling or I like to use MFR. Yet if we take away the labels and just look at the inputs that we can give the body, the explanations we can give and go, does that drive a change in how they express their body and also how they process that and how they think about it going forward? So are we supporting behaviours that drive a positive adaptation or a negative adaptation? So we'll get into the guts of it. So I don't want you to really think too much about what technique at the moment. We're going to dive into techniques in a minute. So some of the common, I guess, pathways that we affect with, I guess, any type of touch, and people experience these without our touch, they happen in the body on their own as well. So you've got your A alpha fibers, which is that proprioceptive information. So very quick to get a message from the receptor all the way through to the nervous system. So things like your muscle spindles and your Golgi tendon organs, they're active all the time. They're constantly taking in information and processing it. So there's times in treatment where we might try and influence these spindles and these Golgi tendon organs to send a message to the brain and get a response. There's other times where we might be targeting like an A beta fiber, so slightly slower at getting the message to the brain. And I'd say this covers most techniques that we apply. So things like proprioception, superficial touch, deep touch, vibration are all covered by a lot of these little receptors. So your Meissner, Merkel, Pacinian, Ruffini, little receptors in the hair. So the body's just a big connected web of receptors. Basically, any technique where you are contacting the skin is going to involve a degree of either superficial, deep touch, or vibration, skin stretch at different or varying speeds. Another thing to consider, and you often see this given as reasoning for manual therapy effects, is mechanotransduction. So basically where you put a force or a load into the tissue, it then ultimately drives a response that releases mechanical growth factor, which is useful for replenishing things like muscle stem cells. So you've got to remember, as much as we are putting mechanical force in the body, when people walk around, they lift stuff, they move, they go about their day-to-day life, they're also putting force into the body. So something I'd really encourage you to think about, even though we can apply these forces with an intervention, is what happens to the person when they leave our table? Are we increasing their ability to keep generating mechanotransduction themselves? Or is there a trade-off where that's impaired for a period of time? So balancing those scales is, I guess, the art in applying manual therapy. The old nociceptors. So most people, these would have been called pain receptors at college. A lot of clinicians still refer to them as pain receptors, except they're just receptors that, I guess, respond to potential threat or actual threat. So the A delta fiber is that really fast conducting nociceptor, but when you look at the speed compared to some of the other receptors we just spoke about, they're quite slow. So things like rapid changes, or I guess things that it perceives as maybe threatening in a mechanical or mechanothermal sense, is going to stimulate an A delta fiber. You roll your ankle and you tear the tissue, that sharp initial pain, that's that A delta fiber. You put your hand in a fire, that initial big bout of pain is that A delta fiber. But then if we look at a C fiber, so it's got a much slower conduction velocity, but it's going to respond to a multitude of stimulus, and they're very sensitive to chemicals released from damaged tissue. So where someone's had an injury, that C fibre continues to fire. So that's that dull ache that people tend to get after they've rolled their ankle. Everything's happening in the tissue. That C fibre response is ongoing as that is still those chemicals present, or they're still recovering from that initial injury phase. I guess that's where you see some of that emotional response to pain, such as that anxiety and the fear around it. And that's where our education is vital about what's going on in the tissue. And as you probably learned today, that will affect how someone feels or experiences their pain. So just quickly looking at pathways. So call them pathways, orders, levels, however you want to view this. Most of what we're trying to influence is in this first order. So where that nociceptor or those receptors are in the skin and in the tissue, we're trying to change that environment. So most of the time we're trying to make that feel nicer, feel better, drop that muscle tone, have everything, I guess, live in harmony together. But then at the same time, if we misrepresent that and we aggravate the tissue too much, we can end up continually driving that pain. So someone comes in pain and we are aggressive with our technique and we sort of go over the line a little bit and we leave them in further pain. So instead of changing the environment of the nociceptor, we actually create more potential threat for it. So instead of calming it down, we can accidentally wind it right up. So then that second level, if that message is constantly hitting that spinal cord, that there's potential pain, potential threat coming in, the brain's pretty interested in that. So you get a wind up effect. So they're really hypersensitive. And then ultimately that third order, that top level, that's where once that message gets up to the brain, it's processed against everyone's past experiences, how they're feeling, all that information as a group. It then decides whether that threat is something that it should respond to or not. And for some people, that involves creating, a painful experience. So generally when there's pain, it will drive a protective behavior. So it's trying to protect the body as an ultimate sort of function. So little things that can always, underwrite that is like poor sleep, that anxiety, depression. Someone's mental state will have a big effect on how they process information and make decisions. So if you've got someone who's coming in, they're tired, they're not sleeping, they're feeling down, all those things are going to have the nervous system wound up before you even start your session. So you need to take that into consideration before you even pick a technique or think about any type of intervention. Is where's that person at today? So it's not until it reaches the top that it has a chance to process it and then come back down. So you've probably heard this today or in other places. So that is like a bottom up and a top down. So we're just speaking about bottom up. So bottom up is where we're working on tissue, how that influences the message going up. Whilst a top down perspective is looking at how the brain can influence what's happening on a global level. So we can have things like descending facilitation. So that's going to enhance the signals that reach the dorsal horn. So it's basically going to let those messages coming from the tissue come in. So things where people are really, catastrophizing or they're scared of doing behaviors, any environment they engage where they're fearful of that and they're concerned about that area of their body, they're going to be letting those messages in, because as far as the brain's concerned, that's really, really important. And then descending inhibition is basically neurotransmitters get released and they sort of suppress that. So they're really good at blocking some of that nociception and letting those messages of feel good come back through. So some of our techniques, or most of them, the effects that they have is through this mechanism. So physical stresses such as like exercise, manual therapy, dry needling, pick your poison, can actually activate this mechanism. Most people just call it DNIC or DNIC. And that's, the gentle art is balancing out, eliciting that response where you're getting the brain on board with calming things down and then not either overworking the area and making that signaling worse, or ultimately giving them ideas or beliefs that change the way they behave and make them, more scared to engage in things they want to do or they enjoy doing, haven't really worried that it's going to get worse without treatment. So when they leave the clinic, they're constantly thinking about that problem in a negative light. So instead of having that inhibition effect, you'll end up with that facilitation. So a really good treatment can be undone quite easily with a very average or a poor explanation. And I guess this falls back to how we're trained. Like our initial training doesn't really account for people in chronic pain. So a normal response to pain is we have that D-neck system kicks in and pain's decreased. And we're very good at trying to inhibit pain on our own. So the body's very good at working that out without anyone telling it what to do. But then in those in chronic pain, you have changes at the brain level. So instead of having that response activated, it tends to set off an alarm. So it starts promoting that nociception and it decreases that inhibitory behavior. So if you've got someone coming in and everything indicates they're a chronic pain, I guess, patient, or they experience it or they suffer from it, however they prefer to term it, and you're thinking purely from a tissue basis that you're going to work on the tissue and potentially add a bit of stress into the system, hoping to trigger that inhibitory response. But if in doing that on a chronic pain person, you're going to get the reverse. You're actually going to create more nociception and decrease that response. So when you're looking at the chronic pain person, you need to be thinking about, I guess, those feel-good techniques, what some would call like yes-deception. So trying to create less stress in the person, less stress in the tissue, rather than trying to worry about any type of mechanotransduction or, I guess, an irritation or counter-irritation effect. So just quick note, like looking at tissue healing, so understanding where someone is at. So a lot of models of thinking around tissue will say there's a dysfunction or a problem in the tissue. So as we dive into each one, we'll see that's very rarely the case. If, however, they have had an injury, you're going to go through a pretty standard tissue healing cycle. So there's going to be an initial injury, that inflammation and swelling phase, a repair, and then a remodeling. Depending on the type of tissue, that remodeling can take 3 weeks, it can take 12 months, for some people, even longer. So in those initial stages, no matter what the person is, you really just need to support that process. So your inflammation and your swelling, we're not trying to stop it. It's part of the process. There's signaling that occurs in there that helps make the next stage occur. So if you stop it, you're actually going to delay that healing. So something like inflammation and swelling, if you have too much of it, you have a lot of increased pressure in the tissue itself and then on the nerve endings within it. So just trying to create a good environment for that person with something like lymphatic drainage is probably all you need to do. It's a gentle touch. It decreases that pressure. They feel better from that light touch. You still get those mechanoreceptors stimulated, but then you're not overworking the tissue either. So if you look at just this list, MFR, you can touch the skin. You can do it gentle, you can do it soft, you can do it firm, you can do it quite deep. You can do it aggressively, but it really comes down to the patient. So if they find it painful, then it's painful. If they find it enjoyable, then it's probably enjoyable. But if they respond to it negatively, that gives you an indicator for next time as to whether what they experience on the table and how they respond after it matches up well for that person. So there's some other things too, like you think about big things like your instrument assisted, like your scraping tools. Same with them, you can choose to use them soft, gentle, hard, firm. You can be aggressive or you can be nice with them. So it's entirely up to you how you apply a tool. So same with cupping, you can use cupping quite gently on the skin, or you can put a lot of pressure in that cup, and that's going to change the sensation and the signaling that occurs. Even the old massage guns, which most clients have gone and purchased probably last Christmas, I'd say there's a big increase in clients with massage guns. So even something like that, you can have light touch, firm touch, vibration, yet a lot of people will be trying to rip in. So we've probably all seen bruises and tissue damage off the back of that. Just quickly looking at the different types of tissue we're trying to fix. So things like muscle, it's very much just follows the direction of the nervous system. So if you don't load it enough, you'll get wastage. If you overload it too quickly, too soon, you'll get damage. Sufficient overload, you'll get some growth. If you have that adequate load, you'll be able to maintain it. So when we're treating muscle, what we're trying to do is just maintain full range of motion for that person, and then just regulating that tension for them. So if they're too tight and they can't get into a posture or position to start with, they might find it harder to have that optimal length tension relationship. So with muscle, tone is probably the thing that we're looking at as a measure of whether they're responding to our touch or not. But then we can also look at that range of motion. But as far as driving that adaptation, a lot of it is based off information from the nervous system and how happy everything is in that area. Onto things like bone. So things like bone are very tough, but they're actually quite, I guess, elastic or springy as well. So they do a great job of absorbing large forces. Obviously, there's too much of that. You can have a stress reaction or a fracture or a complete fracture of a bone. So things that we can do around that is looking at treating muscles, because they act as a really great shock attenuator. So they help the body, I guess, dissipate or share that load evenly through the body. So if you've got a muscle that's way too tight, it doesn't have full range of motion, you can't redistribute load very well through the body. So as therapists, how we still look at muscles is still very relevant, even though we're not directly affecting the muscle. A lot of it comes back to the nervous system, but we still want that good tone. We still want that good movement. We still want that responsiveness from it. Even things like fascia. So a lot of the time when we talk about fascia is a lot of therapies are based around the fascial model, except I guess the harsh reality is our ability to change fascia with our hands is almost slim to none. So mechanical stress can change it, but it takes a lot of force and a lot of time, most of which we don't have available to us and we don't have the time available. But ultimately, fascia is very similar to muscle, where it adapts to the loads that are imposed upon it. So over time, fascia will remodel if someone can move well enough and they can put load through that tissue. So the fascial model, I guess, is so popular because it is quite effective with treating, where you're applying varying degrees of tissue tension over large areas of the body at varying rates, varying depths, varying speeds, so that there's no question that the technique is quite effective. But the explanation that normally goes with it is that we're breaking fascia down, or that they're full of adhesions that need to be broken down, or else they won't be able to move properly. Yet, if we can't break tissue down, yet we're seeing changes within an hour. So a time frame where to really change tissue, if we did have the force available, it's just not available to us. And then looking at how long it takes for that tissue to turn over. So you're looking at months to years. But what we're changing is how that person can express their movement. So if someone has tight muscles, they can't move very well. So if they can't move well, they can't change how they put that force or that load through or over that fascial tissue. So the fascia very much works in with the muscle and the connected tissues together. So same looking at bone. If you're treating bone, there's still relevance to looking at the fascial model. So where someone can and can't move, where they have tension, where they don't have tension. But then purely thinking about it from a fascial point of view and giving an explanation that they shouldn't be doing these things until their fascia is changed, or without us changing it, might change their behavior. So same with the muscle, is saying, oh, this isn't good enough. This is too tight. You're putting more stress on. You're going to cause injury. If that changes how they behave or act, even though the treatment was effective, if they're too scared to move or engage, or they're not encouraged to engage because of our explanation, they're actually worried about their body. And then looking at little things like nerves. So very, very small, pretty much impossible to palpate, use a bucket load of oxygen. So they respond to things like tension, shear, compression, limb movement. You've got receptors everywhere in the body, and you've got nerve endings everywhere in the body for the most part. So a lot of the time we'll get these little like entrapment neuropathies where the nerve won't move very well through the tissue, or we'll have a decrease in, I guess, oxygen to the nerve. So it'll respond to that as well. So as a therapist, we're constantly trying to weigh these things up So if you look at nerves and they don't like having blood flow removed from them, and you've got like a muscle that's really, really tight. So if you think of that internal pressure, it's going to put pressure on these nerve endings. If it's constantly contracting, there's a metabolic cost to that. So it's going to be using oxygen and creating metabolic waste. And then if you think from a fascial model, if that tissue's tight, it's pulling on the fascia and the connective tissue. So all those things can create irritation around the nerves. But ultimately what would change is how those nerves feel in their environment and the signals which they send up to the brain. So if something's painful or provoked, it might tense up in a guarding response. So whether you're trying to target fascia, whether you're trying to target muscles, whether you're just going after the nervous system, what you're trying to create is an environment where all those things are happy together. So depending on the technique you might choose, it's not really that important. What's important is how you apply it. So you could use cupping on a tight muscle or around an irritated nerve. Now, if you pull that on really, really hard over the irritated site, the outside of the cup will draw down really tight and the skin will lift up. So that outer ring of the cup will essentially create a tourniquet to the tissue inside that area. Now, for some people, that might be enough stress to create that descending inhibition, or a little bit of pain, treating pain. But ultimately, you haven't created the best environment for the nerve. So you might argue some dry needling throughout the muscle might drop the tension. And for some people, it will drop the tension, and therefore you have more space, less pressure in the muscle, everything moves better. Some people have a very small reaction to needling. Other people find it quite provocative. So in the art of applying needling, if you overwork the tissue or you overstimulate the nervous system and they have a negative response, needling, instead of creating less pain, might wind that person up. And then if the next day they're left with a lot of needle soreness and they're not moving very well because of it, you've got to weigh that up and go, okay, is them not moving creating enough blood flow in the tissue itself? And then are they discouraged from moving? So as therapists, we're constantly having this battle about which technique to apply, yet we've got to think how that technique affects each of these areas. So when you go back to like asking clients back at the start, like what they've experienced in the past or what's worked for them, but also what type of adaptation that we need to create. So if someone wants to overload a muscle and they're trying to build some muscle, we know that there's going to be times where they get that sufficient load, where they'll get that little bit of growth with minimal pain. And there's going to be times where they might be tired, fatigued or stressed, and it's going to be too much for them to cope with. They might lose the control of their technique, and instead of controlling that load, they put it through tissue haphazardly, and you get too much too soon, you get a bit of damage. So you really got to understand where they've come from and where they want to go. So for an athlete who's constantly training and adapting, we shouldn't be thinking which technique to use. We need to think for their muscles, what state do I need them in? So they've just had a big workout today and they've got another one in 2 days' time. Do I need to try and change the fiber orientation or anything, the muscle at all? Or do I just need to calm the nervous system down so they can move a little bit better tomorrow? They're not as sore, they're not as aggravated, and get a nice active recovery so they're ready to go again the next day. They might also have just finished a large race or something and they're very tired, they're very fatigued, they're very sensitized. Race day, I guess if you're going to get injured, do it on race day. At least you're pushing yourself to your limit. It probably shouldn't happen in training and you don't want it on race day, but that's when everyone's going to leave it on the park or on the field. So they might push themselves a lot. So in those following days, you're not so much trying to change the tissue, you're more just trying to calm the nervous system down, understanding there might be a bit of tissue damage there and a little bit of swelling and inflammation, and that's normal. So we just need to support them through that time. So something gentle again, like what some would call a flush or lymphatic drainage might be appropriate. For your average day-to-day person, their tolerance for load might be quite low. They might sit at a desk all day, not do too much, and something as simple as gardening might be enough to put them in a different position long enough that the muscle gets a bit cranky. But again, they've also never experienced that position. So just because they got pain out of it, it doesn't mean there's any tissue injury. What we're trying to do is change the information that their brain gets, both in the local area and also as a whole. So even for that person, once you rule out anything major, just general light treatment will still be quite effective. And give them time. So they might take 2 or 3 days to settle down from that, I guess, that effort that they've put in. Again, going back to bones, so if we're treating and you've got someone with, say, shin splints or medial tibial stress syndrome, and you're thinking, how do I remodel the bone? And you spend a lot of your session putting needles into the bone or driving your thumb. Heaven forbid you start scraping at the bone, cupping over the bone. So a lot of the time people are thinking about blood flow or trying to create a mechanotransduction effect on the bone. Yet, if you just zoom right out for a minute, look at that whole system. What is the tone like in the rest of their shin, their legs? How well can they move? Are they not moving well or avoiding movement altogether because of pain? So as therapists, sometimes we need to address the pain factor first if it creates better movement in the client. Yet if the whole session or most of it you focused on trying to break down that bone or trying to remodel it or working into that area, the whole time they're thinking about how sore it is, how they've got damage in their leg, not looking at supporting how they feel about it. So if you're constantly talking about the bone, talking about the stress reaction and everything's targeted just at that, that's where you're sort of treating the tissue. But to treat the environment, look at what a bone needs. So it still needs load, but it needs to be modified. And then if you look at the role that muscle has in attenuating shock for a bone, simply dropping that muscle tone in a gentle way around that area will decrease pain, allow them to move a bit better, but also the muscle can attenuate that shock, which instead of putting it all into the bone, you can actually dissipate it now throughout the tissue. As well as minimizing how much time you spend looking at the bone, what you're doing is setting them up so overall, their whole system's less stressed. You're sending a lot of signals from a broad area about feeling better, feeling good. And then your advice is around what you need to do for a stress reaction. So not telling them to stop everything, but not telling them to just go start jumping off rock walls straight away as well. So that's where using a physio or an ex-phys in conjunction for treatment can work really well. But our goal as therapists is to set them up ready for that adaptation. So if you're saying we want you to start weight bearing and walking, and we've just spent our entire session or a good part of it poking and prodding at this sore bone, and they're sore then for the next 2 or 3 days, you've got to weigh up, are they now moving better and more freely with less fear off the back of that treatment? Or are they going to be sore from it? But we justify that by saying, well, we need to do that to that area to remodel the tissue. Yet if we take that tissue-based approach and they can't then apply stress themselves, they can apply stress every hour of their day if they want to. And they also get to experience it and get growth from that on multiple levels. Whilst if we just zoom in on it, we can actually minimize that and take it away from them. So same from a fascial point of view, like there's a lot of time spent talking and looking at fascia, but also like what's wrong with it. Yet it's a very slow adapting tissue. The ground substance can change and it changes rapidly. But as a whole, like purely looking at fascia as an explanation isn't that helpful to our clients. What is helpful is how well they move. And you can look at that as a global thing and not just a single tissue thing. So if they're scared or they're new to a movement, they're probably not going to be very good at it. But if you can break that movement down into pieces and help them move better or feel better through that movement, it's then about time and learning a skill and building that up. So when we give tissue-based explanations around fascia and someone does that 5 or 6 sessions, they feel a bit better, but they go, oh, I've done this 6 hours worth now or 12 hours worth and I come back and I've still got adhesions, I've still got problems. But they go, I guess that's just me. I'm always going to have those problems. And then instead of realizing that it's going to take time and there's multiple systems at play, you've shifted everything into one little bucket of fascia. And same with the nerves. So the nervous system's probably jumped up in popularity the last couple of years. But again, if you say nerve to someone, they generally get a little bit scared straight away. So when anyone hears nerve damage or disc, they tend to worry. So if our whole conversation is just about nerves and you're not checking in more about how they feel or how they're responding to our touch, you can accidentally have the same effect of having them worried that their nerves don't work properly, rather than helping them appreciate how these tissues are responding to that environment. So it doesn't matter whether you're using a cup, a massage gun, tape, there's multiple ways you can engage, and a lot of them have similar outcomes and similar mechanisms for acting. But because we're taught this tissue-based model, we tend to revert back into a modality when we think about treatment. Instead of thinking, what does this person's tissue need to adapt? And what do they need to understand to adapt mentally to it as well? So respecting both that bottom up and the top down process can be, I guess, a juggling art. And that's why there's never going to be one technique, one modality. Yet there's always going to be new modalities because you can sell workshops. And that's not the worst thing in the world if it's a new way to engage with the body. And as therapists, we're all going to have our preference. There's people that love to needle, there's people that love to cut. The art form is learning how to stimulate the right response and how to still guide your client through the process. Just quickly, so just looking at tendons. So tendon's probably the one where it sits in the middle for us. So should we be aiming to change it? The tendon will generally adapt on its own just based on load. So putting extra load on the tendon, generally off tendon, you'll have a bit of pain. So if you irritate the nerves around it and that changes their behavior, there's less load through the tendon. But then if you approach not trying to change the tendon, but change their pain, someone will load better, move better, have less, I guess, impediments to loading their tendon and doing strength-based exercises to build that up. So for us, a lot of it, in most of these cases, comes right back to pain management rather than tissue management. So when we are treating, we tend to look at tissue and go, how do I change it? Yet if we look at it from a pain management point of view and then an education point of view around behaviour, we can give them the right advice to create adaptation in these tissues. So always treat from a place where you're trying to promote the adaptation rather than changing the person. And I'll just
Oh, thank you, Dan. I was looking at the feedback coming through during that, and you have really, really hit a lot of people's positive buttons and a lot of really good responses to your presentation. So I've got a feeling you're going to get requested to do more. Have we got time for a few questions?
I sure do. Is it just my face coming on your screen? My computer is doing all sorts of things.
We've actually got, you're still in share screen mode. That's the one.
There we are.
Okay. First question from a couple of people is, what effect does pain medication, they've said local Voltaren, but I assume they mean any analgesic, change the choice of treatment for chronic pain?
Sorry, is the question that, is the question? Yeah.
Yeah, sorry, actually the questions, I'll have to sort of reform it. What effect does pain medication and local pain relief have on your choice of treatment for chronic pain? In other words, if the clients soaked themselves in Voltaren before they came in.
Okay, yeah, so they've already used pain medication prior to treatment.
Yeah, I'm assuming that.
Yeah, that's quite a common one. So I look at that and go, okay, so they've already taken something which has its own mechanism interfering in their perception of pain or what they're processing, just through a different pathway than what we would. So I'll always revert back to a very conservative approach when it comes to the pain management side of that, especially. So it's really hard where they are on pain management and they want really deep or aggressive work. I generally won't be as aggressive with my hands. I'm a manipulative, sneaky son of a bee, and I will use my words to talk them through the process. So if someone, say, want a deep tissue and they've just had a whole stack of pain medication or dope themselves up on creams, their ability to give me feedback is diminished. And also, like, what messages are going to come through off the back of that medication are diminished as well. So I might still work deep, but I'd try to get there slowly, softly, and gently. But most of the time, I'll try and aim my work towards a bone or a structure that I know they're aware of. So someone says, I want really deep work on my glutes or on, say, a hamstring. I will work in and go, can you feel that firmness? Yep, that's your femur. All right, so we're still working deep, but because you've taken pain medication, your ability to feel it is a bit diminished, but you can feel that fullness. And without them having to feel the sense of pressure or that sense of pain, in their mind, if I'm working down and when I push against the tissue and I'm feeling a femur, how much deeper can I possibly go? So the trick is, I guess, to use your words and the imaging that they're going to get to change their view of whether you're working deep enough. I hope that makes sense. Otherwise, I generally won't give in. I won't be overly aggressive if they're doped up on pain medication, because as much as they may want it, we've still got an obligation to do no harm. And I've got to remember that their ability to give me accurate feedback has been altered. They don't need to understand or respect that fully, but as a clinician, that's my responsibility. So yeah, I prefer to see people when they're at their worst. I know they may not want to come in not on pain medication, but I really like to see how they move and experience things when they're not on medication.
Okay, another question. Why is there such an emphasis on rolling of soft tissue and fascia if the research shows that it takes a lot of time and force to change it? In other words, why do you think what you were talking about is still such a popular model?
I actually think it's popular because it's quite relatable, the way they talk about it. So, for instance, my big mustache bar, all right, so that's an instrument-assisted soft tissue manipulator, or you could use a cup. So a lot of the things that we're doing, whether it be with our hands or with our instruments, we're gauging that response by how the tissue feels before and after and how it moves. Yet when you do MFR, it's that slow sinking, or you can go firm. You really ask the client how they're feeling. You involve movement and you will feel the change in the tissue, but that change isn't structurally happening in the fascia within that time frame. What change is the information from the receptor to the brain. The brain goes, oh yeah, that feels good. That muscle tone drops off. So instead of having something that wants to be in a protective state, it can actually settle down. So we will feel that softening underneath our hands, and that's not a bad thing at all. But the issue is when therapists think that they're trying to break tissue and something's really tight. If something's really tight, it might be protective. If something's really tight, there's usually a really good reason. It's either very protective or it's been like that for a very long time. So when you approach it from I need to break the tissue down, if there's more restriction, then I need to do more of this technique, and you overload that nervous system, you might see a change initially in the tissue. And in the clinic, in the practice, that seems like a good thing. But then if they're sore the next day, or you actually do cause tissue trauma, there's a degree of healing that needs to occur. So if you look at the timeline of how slow fascia is as a tissue to turn over, that adaptation isn't going to happen in an hour. It is going to happen over not days, more likely weeks, months, years. So if every session we only look at how we change tissue in a session, it's easy to go after it aggressively or only think through a fascial model. So I think it's quite relatable for therapists to go, well, that's what I feel. Here's this beautiful package. I think that's why we flock to it. And I don't think it's a bad thing. But when you look at what we now understand around pain, and you go, oh, so how they think about their body and how they behave can inhibit or facilitate pain. And if you want someone to move, which is in a way that's going to be positive and it's going to put as much force as you can safely to drive the adaptation of the fascia, do you want somebody scared to move, or do you want someone who's confident to move? So if your explanation is done in a way where they feel that their body's not yet capable of doing those things, and the only way to be capable is to change the fascia, deep down, some people will take that as, okay, my body's not healthy. Yet that adaptive process is ongoing. So does that make a bit of sense, Dave?
Yep. Yeah, that makes sense to me. Look, we're getting